Hello everyone, I'm Dr. Saurabh Dixit and welcome to my channel. So today, as per promise, I've brought one more interesting small topic for you, and this is again a very important topic. So not taking a lot of time, I'll straightforward take you to this scenario. Personally also we get a lot of patients with this kind of complaint that there is a painful or there is a swelling over the neck and this is moving with deglutition. So I'll give you a brief history of this patient. Swelling, mobile swelling over the neck, moving with deglutition. This is what? Or there is a neck swelling. If you see only the image, it is showing you the neck swelling. I'm not given any clinical history, but I'm giving you a case scenario. Let us make a case scenario. A 26-year-old female presenting to you with swelling over the neck, and this is moving with deglutition and also with protrusion of tongue. The question ends here, you know what it is. So let us keep a differential diagnosis window open, and we have this kind of scenario. How we'll approach to this question from examinations perspective, also from clinical rounds perspective, also from viva perspective, also or as a surgeon in general. This is what is very important. So let us try to evaluate this. Now you must be knowing by this time what we are, because if you see the second image, you can guess that this is a case of thyroglossal duct cyst. Very good. So let us try to understand each and everything in and out about this, and let us try to understand what are the concepts that we need to understand. So when we talk about a thyroid swelling or when we talk about the neck swelling, so this is what is very important. So neck swelling or a thyroid swelling, how we approach. Now in this case, when we have a neck swelling and that too in the center of the neck, now you are thinking that there could be two differential diagnoses. Now what could be differential diagnosis? It could be a thyroid, it could be a thyroid swelling, or it could be a thyroglossal duct cyst. Now these are two things that we need to keep. There could be other things also, but these are the two primary things. So how to see? Now these swellings are enclosed in the pretracheal fascia. So whenever you deglute, you drink water, you eat. So there is movement of this swelling also. So the very next thing that you need to check is the movement. So the movement of swelling with respect to two things. So the movement of swelling with deglutition and the movement of swelling with the protrusion of tongue. Now there are two important things. So protrusion of tongue, why it is important? Just wait for 2 minutes and then we will see. So protrusion of tongue and deglutition. Now try to understand, if it is a thyroid swelling, you know, thyroid swelling, so always remember it will move with deglutition, but it will not move with protrusion of tongue. However, if it is a thyroglossal duct cyst, it will move with protrusion of the tongue as well as deglutition. Why? Try to understand, a thyroglossal duct cyst is connected with the base of the tongue, and therefore with the deglutition as well as with the protrusion of the tongue, it is going to move forward. So one thing is clear, that we have a thyroid swelling and now we have certain things in our mind. Now let us discuss the concept of thyroglossal duct cyst on which this question is asked, or the today's case scenario is based. So when we talk about thyroglossal duct cyst, now this is where the things will start. So thyroglossal duct cyst, what it is? So in a layman's language, we can write as that it is cystic enlargement of a persistent thyroglossal duct. So when we talk about cystic enlargement of persistent thyroglossal duct, the very next question is, how is this possible? Now the reason for this persistence of thyroglossal duct is, answer is due to failed regression. Now you must be thinking, sir, how is it possible that it has failed to regress? Do you know there is a deadline for submission of a blueprint of a body? If we need to finalize a thing, we need to finalize it by 8th week of life. If something has to be deleted, it should be deleted by 8th week of life, else it will be present in the newborn also, or it will be persisted. Like if you talk about Meckel's, what is Meckel's? It's a vitellointestinal duct which failed to regress beyond 8th week of life. So once the 8th week window crosses, it has to be present now. It could be vestigial organ, that is different thing, but it is there. So failed regression of the thyroglossal duct beyond 8th week of life, beyond 8th intrauterine week of life. Now the question is, there are so many things which fail to regress, but they don't convert into a cyst. How is this possible that it converted into a cyst? Now here comes the role of the epithelium. So if you talk about the epithelium which is present in this thyroglossal duct cyst, this is what is very important. This is pseudo stratified ciliated columnar epithelium. So pseudo stratified ciliated columnar epithelium. Now here the things come into the role play. So ciliated columnar epithelium, what is there? So suppose there is a cyst which is present at the time of birth. So at birth the cyst is not present, but the duct is present actually. So at the time of birth the duct is present. Now you have to understand that we have an active epithelium. So these cuboidal epitheliums will have tubules, and these tubules will secrete some content, and this is going to cause what? The cystic enlargement of the things. So there will be cystic enlargement of things. And why there will be cystic enlargement of the things? Because of the active secretion. So do you know that the transformation into a cyst happens during the, you can say, the process of evolution, and the complete cystic enlargement happens by the second or by the third decade. So by second or the third decade the cyst actually forms. So remember, the thyroglossal duct cyst, this is a congenital anomaly. So first of all you have to understand that this is a congenital anomaly which is present at the time of birth, but the cystic transformation actually happens at the time of what? At the time of the second decade, or the you can say the third decade of the life also. So this is what is very important. Now what is going to be the future of this cyst? Now this is a cyst which will keep on enlarging. Let's take it as a balloon. If you keep on blowing a balloon, what will happen? It will increase in size, get distended, and there will be two things. Either the friend sitting next to you will poke a pin and burst it, or it will spontaneously rupture. So rupture is inevitable for this cyst. It will rupture, and you have to keep in mind that it will rupture. No one can, you can stop it. So what is going to happen if it ruptures? So why the rupture happens? You know that either it could be iatrogenic, rupture, or it could be what, students? Spontaneous rupture. So spontaneous, how it happens? Like you are tempted to take an FNA from this, thinking it to be a thyroid cyst. Therefore it's very important to clinically assess the swelling before you take any decision. So if you go for FNA for this, so the cyst will get ruptured. The problem is that the cyst will collapse also. But since this is an active cyst, it will keep on producing some content, and every time a granulation product or plug is going to form near it, so what happens? The cyst is evacuated, it will collapse. You are very happy that I got rid of the cyst. After 2 weeks or 4 weeks, again something is coming out. Again you present with a distended swelling, and automatically again this is sloughed off. Why all these things are happening? Let me tell you. Every time the plug wants to form it. So suppose there is a epithelial plug which forms here. So there is an epithelial plug which forms here. The cyst will continue to distend, and again it will wash off this plug. So over the time, slowly and slowly, this surface becomes what? Epithelialized. So there shall be epithelialization of the orifice. And once there is epithelialization, this actually converts itself into a what, students? A fistula. So intermittent discharges happens, and then there is a persistent opening. So the cyst is congenital, but the fistula is acquired, and it is acquired because either of a spontaneous rupture or an iatrogenic rupture. Now this is what is very important. The next is, what could be the potential risk of malignancy? Students, less than 1% risk of malignancy is there. Less than 1% risk of malignancy is there in this cyst. The next question is, what malignancy can arise and what can never arise? Remember, it is a part of the medial system of the thyroid. So you know, thyroid develops in two parts, the medial and the lateral. The lateral part contributes to parafollicular cells, and medial part contributes to the follicular cells. So via follicular cell any cancer can arise, but medullary thyroid cancer can never arise. So yes, if it is asked in your exams, what cancer can arise? Answer is it's a papillary CA which can arise. Now the location, if you talk about most common location, the most common location is the subhyoid or infrahyoid. So subhyoid, near the hyoid bone, it actually gets the place. So it may be retro, it may be supra, so it may be juxta, lot of things are there. Now what could be the management of this? It's very simple. You have to go for en bloc cystectomy. En bloc cystectomy. What do you mean by en bloc cystectomy? Now this is what is very important. Now try to understand what is this block. I understand that cystectomy has to be done. So this is the cornu of the hyoid, this is the body of the hyoid, again this is the cornu of the hyoid, and around this suppose you have a cyst. So one thing that you need to understand is that you will excise the cyst like this, just see. So here also you are going to excise it, here also you are going to excise it, and then let us remove this part, let us remove this part. Okay, so you can see that hyoid, central part of the hyoid along with the cyst has been removed, and this is what is known as the en bloc cystectomy. This was for the first time done by cyst trunk, and that is why this is known as cyst trunks surgery. So this was a small crisp video discussion for today, and you can see what is en bloc cystectomy. This is what students known as en bloc cystectomy, where you divide the hyoid, the central part of the hyoid, and we go right up to the maximum proximal location. We can search this thyroglossal duct and we can ligate it. So I hope you enjoyed it. Do subscribe to my channel. Do comment in the comment section how you like what you liked about the video, or if you have any other topic in demand you want me to discuss, I'll discuss. So do share the link with your friends so that they are also benefited. Thank you.